Good. So welcome. Thank you, all of us, or all of you guys for joining us today, specifically for the presentation, Leveraging Colorado's All-Payer Claims Database to Understand Long COVID Burden with Dr. Marcelo Perraillon. Today's presentation is brought by the Social Behavioral and Economic COVID Coordinating Center, or SBCCC, at ICPSR. For those of you who are not familiar with us, we are a Center for Communication and Collaboration among NIH-funded projects undertaking social, behavioral, and economic research on COVID-19. If you haven't already, we hope you'll take a moment to visit our website. You can join our mailing list to receive the occasional update. So now I want to introduce today's speaker and turn things over to him. So Dr. Marcelo Perraillon is an associate professor in the Department of Health Systems, Management, and Policy at the University of Colorado Anschutz Medical Campus and a President's Teaching Scholar. His research focuses on the evaluation of the effects of healthcare policy on costs, quality, and outcomes. Areas of interest include long-term care, Medicare, Medicaid policy evaluation, and cancer care. Before obtaining his doctoral degree at the University of Chicago, he was a researcher at the National Bureau of Economic Research. Dr. Perraillon co-directs the Population Health Share Resources Core at the University of Colorado Comprehensive Cancer Center. And with that, Marcelo, I will turn it over to you.
Thank you so much. Thank you for inviting me. So collaborators and funding, this work is one of my PhD students, Rick DeVos, who is in the meeting, is leading the analysis and it's part of his dissertation. And this work is with Elizabeth Carlton and Sarah Jolie here at the University of Colorado. And the funding comes from the School of Public Health, the Governor's Office, and the Cancer Center here at the university. I have a lot of slides, and I think that I'm trying to go for 30 minutes. I'm going to skip some of the slides because some of the background you're very familiar with. Let me do this. So as an overview, we're using data from the all-payers claims data set in Colorado, which is one of the oldest all-payer claims data sets, and I'm going to explain a little bit more about the data. One big warning or problem, but advantage at the same time, is that we are relying on the identification of long COVID using ICD-10 codes, the U code that became available in October 2021. We're trying to find ways to validate what we are doing, and we are also conducting qualitative interviews with some providers to understand how the code is being used in Colorado. And this is part of a larger project that we are essentially trying to understand the incidence and prevalence of long COVID in Colorado, the characteristics of the population, current comorbid conditions. I'm particularly interested in healthcare utilization pattern, inpatient, outpatient, and in particular healthcare expenditures as well. This is the first stage. This is the long COVID sample that we have, and then we are going to try to use this sample to try to build predictive models that allow us to make inferences about how many people in Colorado have long COVID, whether they have been diagnosed with long COVID in a medical setting or whether they have not been diagnosed yet in a medical setting. I'm going to skip the long COVID definition because you are all familiar with it and the long COVID symptoms. Let me go to the data. Paid claims submitted by payers are sent to the Center for Improving Value in Healthcare in Colorado. This is mandated by the state. It includes Medicare, traditional, and Medicare Advantage, which is great to have because sometimes you get them separate. It has Medicaid, and over 40 commercial payers submit the claims for all the people enrolled in healthcare plans. Usually the lack of time is about 6 months for commercial Medicare Advantage and Medicaid claims. Traditional Medicare has longer delays. And this is important for the state because one of the things that the state is very interested in doing with this project is trying to assess the feasibility of a surveillance system that can use Medicare claims data because they are large, they come very fast. So this is the overall goal of these projects. There are some problems with the APCD. Unfortunately, the health plans cover under ERISA, usually the self-funded type of plans, they do not submit claims to the APCD, although some do voluntarily. There is no data for VA, TRICARE, Indian Health Services, and of course, this is paid claim, so it doesn't include the uninsured population in Colorado. The uninsured population is about 7%. So we have claims available for about 75% of the population in the state. One of the important things is that we're using the 100% sample. So we have the sample of 75% of the state, regardless of the payer, except for VA, TRICARE, and Indian Health Services. So that's the part that is important about this, that it covers almost an entire population in the state. There are a lot of strengths with the APCD, and there's a lot of limitations. When a strength is a large sample, it has multiple payers, it has diagnosis, procedures, date of services, enrollment insurance. We have supplemental plans as well that are required to submit. We have advantages with the dual population that are covered by Medicare and Medicaid because we can get both their Medicare and Medicaid claims. We have service dates. There are a lot of limitations, however. These are billing records, these are paid claims, these are not electronic health records. We don't have lab results, we don't have notes. So we have a lot of uncertainty about exactly what happens with a patient other than the billing that an insurance company received. The data is not linked to vital statistics, so we don't have death or immunizations in the APCD. What I'm going to show today is using a little bit the most available data that we had about a year ago. We are going to receive an update next year to complete this work, and we are trying to get the data to be linked to vital records because we want to understand who drops from the APCD because of death and who drops from the APCD for other reasons like lack of enrollment or leaving the state. There's only there's now information on things that have not been paid by insurance, so there's no out-of-pocket type of things. Compounding pharmacy medications like low-dose naltrexone that is used for long COVID, there are no out-of-pocket data. Unfortunately, there is incomplete race ethnicity information. It varies by payer, but based on what we know about the APCD, it's not a very reliable source of information for race or ethnicity. There's no information on uncompensated care. So there's a lot of advantages. There's a lot of disadvantages in using the APCD for this type of work. For the study, we use individuals 21 and older with at least one claim with a U code from October 1st, 2021 to August 31st, 2023. We exclude denied claim lines, negative payments, and U codes with a date prior to October 1st. There were the prior month, there were several claims that had the U code that it wasn't supposed to be there, so we just removed those data. The index day is the first instance of the U code. So there's a very simple algorithm. Usually when working with claims data, people have developed algorithms to try to identify different conditions using claims. We don't have any of those algorithms. We are trying to work with a linkage between the APCD and the medical records here at the university to try to see if we can validate what we are doing. We are also conducting interviews when we are trying to figure out how doctors are using the long COVID ICD-10 code. Some preliminary analysis tell us that a lot of the people diagnosed with this U code are people that are going to the long COVID clinics in the state. We have 4 long COVID clinics, 1 here at the university. So that gives us a little bit of certainty that perhaps most of the people with this code truly have long COVID, but we are not completely certain of that. To estimate prevalence, we have 2 samples. One that has, for most of the things that I'm going to show, we require continuous enrollment 1 year before the claim for long COVID, 1 year after the claim for long COVID. But we were also interested in trying to see what is the prevalence of long COVID based on claims data. So for that particular sample, we don't require the continuous enrollment, and the denominator is anybody who was enrolled in the APCD during that particular period. Since we don't have information on long COVID duration, we just consider prevalence and incidence are as equivalent. Let me skip that because I'm going to show you in the tables the variables. Comorbid conditions. So we try to understand all their comorbid conditions. There are many indexes that have been developed. We are using the Charleston Comorbidity Index that has been validated to be predictive of 10-year mortality along with age. Because the bulk of our sample is between 50 and 59, Usually in the Charleston, a person with no comorbid conditions has 4% chances of death. An index of 2 predicts about 10% chance of death within a year, and a 3 is 23%. So that's one way of understanding the index. I'm going to show you the particular conditions that people have. One of the challenges of claims data, of course, is that we wanted to understand utilization and patterns of utilization in this population. And fortunately and unfortunately, the ICD-10 codes, there are over 70,000 ICD-10 codes. So we use the clinical classification software developed by the Healthcare Cost and Utilization Project to try to summarize all the ICD-10 codes into clinically meaningful categories so we can make sense of what type of utilization are these people having. So that's besides the comorbid conditions that are conditions that increase the probability of mortality. This is just trying to put all the ICD-10 codes into classifications that make sense. We also use individual ICD-10 codes or things that we think are related based on clinical information with long COVID, like POTS and chronic fatigue syndrome. Unfortunately, there are issues in the use of the ICD-10 code. So the only one that I'm going to be able to show is chronic fatigue. That actually it's a very interesting thing that happens with these patients. Medications is also a little bit complicated. We are currently exploring non-proprietary classification systems because we have thousands of medications that we are trying to put them into categories that make sense. For now, we are using just the name rather than using the NCD code, just the name of the of the medications to try to group them into some categories that are meaningful. For example, trazodone or trazodone 25 milligrams or trazodone HCl all be put into the trazodone category. But again, there are several tools that we can use, but we need the funding to buy those tools. In the absence of the funding, we're trying to find some non-proprietary classifications that we can use. Results, this is the part that I want to spend more time. So we found about 25,000 individuals had a U code indicating long COVID during the study period. There's about 4 million individuals that were enrolled at some point in the APCDs. These are they ever enroll at some particular point during the study period. That gives us about 57.7 per 10,000 or 0.57% of the incidence. Obviously, this is low, although there's so much variability in estimates of incidence for long COVID, but this is definitely on the lower side, which makes sense because we know that some physicians do not use the long COVID code or did not use it in the past. And I'm going to show you some statistics about that. These are the trends on the use of the U code. This is October 2021 to August 2022. It's unclear if this peak is real or simply reflect people that were suspected or are having long COVID that then get a diagnosis code when the code become available. This trend seems to be the more stable one that removes the effect of the novelty of the U code. We are going to have more recent data, but it appears that increases over time, but perhaps there's a level on how this U code is being used. These are baseline characteristics. This is divided between everybody, the 26,000 people, and the people with continuous enrollment. So just to make this simple, we can probably ignore the all and focus on the continuous enrollment sample that I'm going to present a little bit more. The age is 57. The standard deviation is 17, so it's very large. So most of the people are between 40 and 75-year-old, which is relatively young. You can see that in the distribution of ages, that is 36 to 75 seems to be the most common categories. This shows, unfortunately, how inaccurate is the APCD classifying race. In other work, I have APCD data linked to cancer registry information, so we can make sense a little bit better in terms of race, but it is one of the limitations of the APCD. As suspected, most of the people are in urban areas. The Front Range in Colorado is where most of the population live, and then there's the rural area. Colorado is a very interesting state because some of the rural areas are actually wealthy areas. And then we have remote areas that are close to the frontiers in the state. There's a different way of classifying the urban, rural. This is the part that I think is interesting, particularly to me. The larger proportion of people with Medicaid and duals that end up with a UCO diagnosis for long COVID. This makes almost half of the sample. And this is definitely something that we need to explore a little bit further to understand differences in the use of the U code depending on payers. That's part of the qualitative study that we are doing. And this is the part where things get interesting at the same time, not surprising based on what we know. So this is a comparison of concurrent and comorbid conditions before and after the U code. And this is using the Charlson score. So these are the components of the Charlson. This is the average, and that's why I mentioned how to interpret these numbers more or less. But there's some interesting patterns here. This is the change. And one interesting pattern is that obviously there is large diabetes. The Charlson divides diabetes with complication, diabetes without complication. The other for me, because I do cancer research that is very interested in is the increase in cancer-related diagnosis. This is cancer, this is metastatic carcinoma, and this is lung cancer. And you can see large increases for all of them before and after the long COVID. Now, there's no causality in this particular study. This is just a before and after understanding this comorbid condition. So this doesn't mean that long COVID causes any of those diseases. Most likely, particularly when talking to physicians, chronic pulmonary disease, and these things are diagnosed. They are just being identified when the people have problems that are related to the lung. Cancer, we know from other information and other work that there was during the lockdowns, people did not get screens, and then after the lockdowns were relaxed, people are starting coming back, and cancer has been diagnosed at later stages. This could explain metastatic canceroma. Lung cancer, I work with lung cancer screening, and Colorado is one of the states that is in the middle of the country in terms of about 12% of the people who are eligible for lung cancer screening are actually screened for lung cancer. So a lot of this could be just the recognition when people go and they have a pulmonary problems, they go to the doctor, they get a lot of tests, and lung cancer is identified incidentally because of these screenings that they do. But it is a very interesting changes in these comorbid conditions based on Charles. This is the part that is also interesting and perhaps not terribly surprising. So this is the ICD-10 codes using the CCS classification that puts them all in categories. And this is by order or how many we have. These are not mutually exclusive categories, so people can be in multiple ones. Obviously, the most common is contact with infectious diseases that it's 55 before, it's 40 after. This speaks to how claims can be a little bit tricky to use because only 55% of the people had a COVID-19 diagnosis in the claims. And this is kind of obvious in the sense that a lot of people did not go to the doctor when they had COVID-19. They had a home test and it was never entered into the billing record for insurance companies. If you use electronic health records, you may catch more of this COVID-19 diagnosis. There's respiratory signs and symptoms, medical examinations. For me, some of the most interesting was pain. This is pain, not low back pain. This is abdominal pain, and then there's non-specific chest pain, and one that is down here is low back pain. If you put all of them together, about 50% of the people had at least some type of pain when they complain about pain. The other one is sleep and fatigue. So sleep-wake disorders, malaise and fatigue, they make about 30%, and you can see how that changes before and after. So this agrees with what we understand about the presentation of long COVID. For us, also, this is interesting because these patterns are kind of unique. This is not sort of a random sample of people who are 57. And that means that we are hoping that predictive models will allow us to separate and make statements about, well, these are the people who are who appear to be diagnosed with long COVID by a physician. These are the people that share some of the characteristics, but they don't have any diagnosis for long COVID. There are problems with that, of course, because we only have the records if people go to the doctor and complain about some of these problems. A lot of this also looks like other type of diseases and conditions like chronic fatigue syndrome. I'm particularly interested in chronic fatigue based on conversations with physicians that are treating people with long COVID here in Colorado. There is overlap between chronic fatigue and long COVID. And this was something that was surprising to me. So as I said, we had problems with the ICD-10 codes for POTS and other conditions. So this is the only one that we can speak with some certainty about the increase in the diagnosis before and after the diagnosis with long COVID with chronic fatigue syndrome. So 4% is a high number compared to what we will expect from people this age to have chronic fatigue. What was surprising to me was that this increases. I will think that it will decrease or that some people that have chronic fatigue syndrome, maybe they got COVID, they get treated at a long COVID clinic, and then maybe their diagnosis of chronic fatigue syndrome decreases, but it actually increases, and it's a fairly large increase. So this is another thing that we need to explore, this increase in chronic fatigue syndrome diagnosis. And going to utilization, this was also a very interesting set of numbers. And let me just highlight the numbers so you don't have to read all the numbers. These are hospitalizations, and this is the percent of the people with a hospitalization before and after. So before, about 17% or 16% of the people diagnosed with long COVID had a prior hospitalization, which is fairly high. And then after the diagnosis, it reduces in half. This number is particularly high. This is percent of the sample with at least one ER visit. So we have 40% of the sample, and then it goes to 32% of the sample. So this speaks of heavy utilization of inpatient and emergency department visits before long COVID diagnosis, and a reduction of this after long COVID diagnosis. Outpatient visits goes the other way. The mean is 8.6 before, and it goes up to 9.55. And visits to a specialist also increases from the pre-period to the post-period. And these numbers are curious. It's very difficult with claims to identify a specialist, so we did our best to try to remove visits where we didn't think that they were a specialist, and how you do these changes. But however we did it, it is consistent that there's a change from before and after that increases after long COVID. And the number is curious because when you read estimates about how many specialists do people see before they are diagnosed with an autoimmune disease, every time I read that type of studies, it's about 5 visits to a specialist. So we are ballpark with the same number. So this points towards high utilization of inpatient and ED visits before the person is diagnosed, and then a reduction. That there's no causality. There's a lot of factors that could explain. One factor could be that once these people go to a long COVID clinic or they are diagnosed with long COVID, perhaps there's better management, and that prevents some of the hospitalizations. The other explanation, of course, is that it could be that simply the disease is improving and there's no need for hospitalizations or ED visits. That's a possibility. We don't know for certain how many of them have true long COVID or how many simply have a reduction in symptoms after 6 months. And then medications, again, it's the hardest part, but these are the most common medications: prednisone, medications for nausea, inhalers and breathing, cough, inflammation, more inhalers, acid reflux. But the most common was antibiotics, and particularly after the COVID diagnosis, there's a very large proportion of people, or there's a lot of antibiotic utilization and also pain medications, which makes sense with 50% of the people with pain. I'm hoping that we can have better tools to try to classify these medications, but this also agreed with the symptoms that I showed you before. And then there's a different way of, so what I showed before explains sort of this change in the pattern of utilization and adds more detail. There's a very easy way to summarize this, which is not perfect, but it's showing expenditures instead. So healthcare expenditures is utilization time prices, and in this case, prices are payments. So we can thought of expenditures as an index or summary of utilization weighted by the payments from insurance companies. It's not perfect, of course, because payment depends on many different factors. For private insurance, is negotiations between providers and insurance. Medicaid is usually lower payment, and then Medicare has payments in between Medicaid and private insurance. We calculate expenditures 360 days before and after a long COVID diagnosis. We divide it into 30-day periods. For the things that I'm going to show out of pocket is coinsurance, copay, and deductibles. This is a little bit preliminary. The post data period needs to be censored. And we are using a sample that has continuous enrollment 1 year before, but then they could drop from the APCD after the diagnosis, which means that we have to censor those calls. These calls are usually right censored. So we did a very crude censoring method that I'm going to show. And this is, to me, this is the summary of the talk, which is essentially about 8 months before they are receive a long COVID diagnosis, or they have a claim for long COVID. Expenditures increase, 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 increase. This is the month of diagnosis. They keep increasing and then sharply decrease. If you are familiar with other diseases, this is the blue line is allowed payments, and the payment it's by plan, and the difference between two is roughly copays, deductible, or coinsurance. But if you have seen this before, this looks very, very similar to other chronic conditions or conditions that are hard to identify. I've seen graphs identical to this for dementia, like there's a increasing in cost and then decline in cost. This is also related for medical debt. One of my colleagues here at the university, Lauren Nicholas, does research linking Medicare claims to financial information, and they show like increased debt, a diagnosis for dementia, and decreased debt as well. Other conditions like MI is going to look flat expenditure, acute expenditure after MI, and then a reduction that perhaps it levels up. But this to me is the summary of everything I've shown you, that there's increased utilization before and then things stabilize. This is the same graph, but for patient burden. Remember, there's a lot of Medicaid in this particular sample, and copays for Medicaid are essentially nominal or negligible in Colorado. So it's a little bit less than 10% on average, but depends on payers. And this is the summary of the aggregated. So maybe you can pay attention just to the plan pay amount, because it includes only what insurance companies pay. In the pre-period is 15,000, and in the post-period goes to 12,000. Now, this is the number that we need to censor, and using a very basic method of censoring, the post is between 12 and 15. So we have like this, it's either kind of the same as before on average, or a little bit lower than before, but still the expenditures show this trend towards high things before and then going down. And this is how it looks for the sample with continuous enrollment. So this matches the sample that I've mentioned before. Increased utilization, it lowers, and it remains a little bit higher than before in the post period, but the bulk of was here, and it is without a control group or without causality. It's very difficult to say, talk about causes, but it could be possible that is the acute, perhaps when the symptoms show up, or it could be that there are reductions in better management of patients. That's what we are trying to get from the qualitative. And I think that rather than summarizing, maybe just mention the next step, which is we are processing the data in similar ways to try to use the entire 4 million people to try to run these models that allow us to make predictions about who may have long COVID but are not diagnose using the people with the U code as the training type of sample. We also want to calculate expenditures with a matched control sample, so we can talk about excess expenditures rather than expenditures. Although, 15,000 or 17,000 on average for people who are 57 is a very high level of expenditures. And then we want to try to see if we can refine the algorithms and to identify long COVID patients using claims data. And I think that's it. So hopefully we have time for some questions. Thank you.
Yeah, thank you so much, Marcelo. That was really interesting. So I want to open it up to the floor. You can feel free to put your questions in the chat. Looks like we already have one, or feel free to when there's a lull to unmute yourself. But it looks like we have two questions from Uche Ofoma. Says, apologies if I missed it, but I'm curious to know what proportion of the population who had long COVID U09 had a prior COVID-19 U07 code.
Yeah, that is it was about 55%. And again, it is this problem that this is not electronic health records, and a lot of people did not go to a doctor and got a COVID diagnosis, perhaps.
Gotcha. The next question that he had is prior studies showed a lot of variable sensitivity, specificity for COVID-19 U07 code, and the case might be the same for long COVID U09. Given the stated limitations, do you think that a combination of prior COVID-19 U07 code and at least one of the long COVID associated condition diagnoses that you listed can provide some sort of quasi-validation for the long COVID U09 code?
Yes and no. Yes, it's a good idea. The problem that no is because I think that we know that a lot of people with COVID never went to the doctor and got a home test, and there's no, and we know that long COVID also happens in people that had a mild type of COVID. That's the no part. The yes part is that yes, that would be one way of doing it. If we manage to get a sample that has some sort of electronic health records and link to claims data, that will be one algorithm that we can try to figure out, okay, what is the best algorithm to identify people with long COVID. We're also exploring I think that most of the people that we have right now have been diagnosed in a long COVID clinic, but we are not certain because it's hard to figure out who actually went to a long COVID clinic other than by the location where they are receiving, where the claim is. Yes. Yeah, so that question is very interesting. Do you know what in the one context the patients usually get the long COVID U diagnosis? Yes. So in the qualitative work that we are doing, what seems to be happening is that there are 4 long COVID clinics in Colorado. One is in the Anschutz Medical Campus. One of our co-authors is the director. It seems that a lot of providers just refer patients to long COVID clinics, and they are given the diagnosis in the long COVID clinic. We know that Kaiser send their patients to the University of Colorado to get diagnosed with long COVID, but that's part of what we are trying to get at with the qualitative interview. We have been asking providers is, okay, do you use this code? How are you using this code? How are you defining long COVID? And do you know of people that are not using this code? Why don't they want to use it? And things like that. But yeah, that's an interesting question.
All right, other questions? I guess while we wait, I'm curious if you could might say a little bit more about how you guys are planning to investigate that, kind of disparity that you see with or kind of the overrepresentation or higher representation of Medicaid covered patients, and kind of looking at what might be driving that.
Oh no. There's always the issue that insurance drives these things, policies about particular payers, but I don't think that's the case. I think that that's derived from so one way that we can do the group that is doing this work, Elizabeth Carlton, they have been working with the state since the beginning of the pandemic in modeling COVID. And I think that their work could inform also about the incidence of long COVID because it has not been even in the way of it has affected more people of Hispanic that identify by Hispanic. In Colorado, half of that population is covered by Medicaid as well. So something like that, but I don't have a very good answer. I've been wondering the same.
Looks like we have another question in the chat. Do you see any disparities in who gets the formal diagnosis of long COVID? For example, patients with more generous insurance plans, certain race, ethnic groups,
Yeah,
etc.
that's related to the previous question. I mean, if we take the data as it is, we will say that half of the people getting the diagnosis are covered by Medicaid or are duals, Medicaid, Medicare. So there seems to be disparities, but in the other direction, as we usually talk about disparities. And that's because even though we don't have a very good race and ethnicity coding in Colorado, 50% of the people with Medicaid identify as Hispanic, so we can guess about sort of the different components. But yeah, this is a very interesting part of what we found. Rick, do you want to say anything about any of this? Please feel free to correct me.
No, I think you covered most of it. Yeah, I think we're getting set up well here for future work on this, like incorporating control groups and the predictive modeling. Yeah, and you know, the thing that I think is most interesting is this change from it seems to be acute care settings to office visits essentially, and we're still trying to totally understand that and validate, make sure that that's correct, but yeah, it's yeah, an area for further research for sure. Just that one finding, I think.
Great. Well, I think we are right at time. So well done, Marcelo. You timed this absolutely perfectly. And thank you so much for coming and talking a bit about this work. And hopefully, you know, as it progresses, we can maybe have you back to learn more about what you find. So with that, I hope you guys have a great rest of the day.
Thanks. Bye.